Excellent.
All right, great. We have 10 people here so far. Welcome everyone.
Hi, everybody.
I'm Sarah Evans, and I host the podcast Bringing Up Betty. Today is our very first, I'm going to call them Bub Blabs, because Bringing Up Betty.
I love it.
So we are really excited to be joined by Dawn Winkleman. Am I saying that right?
Yes.
And she is a feeding therapist with 20 years experience in helping families and children with feeding struggles, feeding disorders, feeding issues, overcome those and help them learn to eat and get the nourishment that they need. And I am, like I said, the host of Bringing Up Betty. And more importantly, I'm Betty's mom. I have 2 little girls. Betty is almost 3 and my older daughter is almost 5. And Betty has a rare chromosome disorder called Potocki-Shaffer syndrome. And she's, with that, got a lot of developmental delays and a lot of other challenges, and feeding was part of that. So she actually, I breastfed her for the first year, but around 6 to 9 months, she started losing weight. And so that was kind of a red flag. So her pediatrician told us to supplement with formula. So we started bottles, and I was breastfeeding and doing formula. And then she was just on bottles from a year until almost 2 years. And then she also, we were trying to get her to eat solids, but it took a lot of work. So we spent over a year in feeding therapy, just getting her used to having food in her mouth and learning to chew. And she's still working on some of those issues. And now we're trying to work on using utensils. But thankfully, she has made a lot of progress. And thanks to the Easy Peasy Happy Mat, and this is a legitimate plug, I'm not just saying that, she now can eat at the table with us because we just put the mat right on the table and pull her little high chair up. And she just goes at it with both hands and loves all food now. We're so thankful, and can tolerate most textures. So, yeah, it's been really fun to have her at the table, even though she makes a huge mess. But we're so happy to have Dawn here. Do you want to introduce yourself, Dawn?
Oh, sure. My name is Dawn Winkleman, and like she said, I have 20 years experience feeding kids of all ages, particularly, usually parents come to me about 4 to 6 months of age when they're about ready to transition to solids. So that's a high age group for me, as well as all the way up through the teen years. And I specialize in feeding and swallowing disorders, which we're going to talk a lot about today, as well as just our traditional picky eaters. So I work a lot with kids with special needs and developmental delays, as well as our neurotypical kids out there who just really struggle too with eating, and a lot of people don't take them seriously. So that's a little bit of my background. I am a speech language pathologist by trade with a master's degree, and I work for Easy Peasy Fun.
Great. And for those of you that aren't familiar with Easy Peasy, I hope that we can tell you some of the great things about it while we discuss feeding.
Yes.
I guess to just start off, I first found Easy Peasy. It was a Kickstarter campaign, and I saw it on Facebook or something. I think it was the NYC baby guy.
Baby guy, yeah.
Yeah, I think he kind of like made that whole thing catch fire, right?
Totally.
And he was pulling up a table like that the Easy Peasy tray was stuck to, and showing that like a kid couldn't grab the edge of it and like just rip it off. And I knew if we tried to give Betty a plate, she would just toss it.
Yep.
So we're very thankful for the Easy Peasy Happy Mat, and now there have been even more products developed, which we can't wait to try. Also, for anyone that's here participating in the chat, on the right side, if you do a /Q like this, but with no space, and then type a question, then it will be tagged as a question for us, so we can make note of it and we can address any questions that you have as we go.
Great.
So let's see, to start off, do you want to just talk about what feeding therapy looks like for a child with special needs?
Sure. So feeding therapy in general can be a wide range of things. We always say in our field that feeding therapy is an art because every speech pathologist who specializes in feeding or an occupational therapist, we all go to different continuing education seminars and we kind of have a bag of tricks. We go through all these different seminars, which actually we're going to be at ASHA tomorrow, the American Speech Language and Hearing Association. And there they have all these different classes where you can get certified in different techniques and programs. And so we know every kid's feeding challenges are different. And so you want to be able to have a therapist that has a wide range of tools, not only in their bag of tricks of what they've attended to as far as seminars, but also feeding products. And so the differences with our kids with special needs as compared to some of our traditional pricky eaters is that sometimes they're nonverbal. So you kind of have to really be able to read into some of their sensory issues, their motor delays, maybe some cognitive abilities, their balance, their posture, all of those things, respiratory issues. I work with a lot of kids with trachs or on ventilators who, the doctors say that they're not able to eat, which is not true. And so being able to kind of have that ability to transition in the mealtime, as well as being able to handle all the medical issues that come with it. I've had several kids, code on me during a therapy session. I've had, several kids, really decrease in their oxygen saturations. Had a few kids with food allergies. I mean, there's a variety of differences in the special needs population, which is one of the main reasons why I love to have parents in on my therapy sessions, because of the fact that, we want all these strategies to kind of carry over. So that's some of the differences with working with kids with special needs.
Yeah. So, can you identify any specific surprising struggles you may have had as a feeding therapist? You talked about someone coding on you. That's
yes,
kind of scary.
Yes, that was scary. Some of the I'll say some funny ones too, so it's not all horrible, but having other therapists work with the same kid at the same time. So I have some kids who are in, behavioral therapy and they're working on some feeding issues. They're also in occupational therapy and they're working on some feeding issues. Or they're seeing a psychologist and they're working on some feeding issues. So having that struggle between, what speech pathologists might say and some of their discipline can be really complicated. Some of their struggles have been, trying to build trust in the relationship after it's been broken when it's feeding, whether it's been, kids have had tubes down their throats or, anyone in a pair of scrubs, because I'm usually in scrubs when I'm working with kids because they get really messy, having that trust that has to be reestablished and having them want me to eat some of the foods that they're eating. Primarily, usually I've drank a lot of breast milk in my day just because, they're like, here, try this in my bottle. I'm like, okay, I have to establish that trust. So drink a lot of breast milk. I've also drank some very odd foods because we, come from different cultures and different backgrounds. And so, eating, foods, especially when I was a vegetarian at a time and having to eat some, meat that I wasn't really familiar with. But those are always fun and exciting, but can be a little challenging in the therapy session. Especially when they ask me to drink some of the breast milk and then they offer it to dad and dad doesn't drink it. So then we have the challenges there too, but right. It's all in good fun.
That's great. So to depart a little bit from the special needs side of things, do you, because I was thinking of, eating the foods that we're feeding our kids, how do you feel about baby food versus maybe the baby-led weaning?
Oh, yeah. Good question. So baby-led weaning is really taking off. I mean, I've been speaking about that nationally probably for about 2 years, but it's, within the last few months, it's just really taking off. And
do you want to describe what that is?
Oh, sure. I'm sorry. Baby-led weaning is an approach to feeding. So it's kind of skipping the purees and going to regular table foods and just being able to have your kids eat some of the same foods that you're eating. So we have our moms who like to make their own organic baby food in their kitchen, which is amazing, or moms who just don't have a lot of time. And so they buy canned or jar baby food. And then some moms who really want their kids to participate at the mealtime at the table and be able to give them their own foods. I love baby-led weaning and the baby-led weaning approach. It's just a lot of parents aren't as familiar with all the pros and cons that go with that. So I'll just kind of talk about a few. One is that I'll have a family saying, yeah, we started baby-led weaning and we've been feeding them table foods. And that's not really what the approach is all about. The approach is basically waiting for the child to have their own posture because they're supposed to be able to sit up on their own. And that's usually around 6 months of age. Because that's the number one fear with kids with choking is if they don't have their posture, they can easily choke on these table foods. Secondly, it's not about us feeding them. It's about them being able to explore and pick up those foods and eat them themselves. And so they have to have some of the fine motor movements and the gross motor movements to be able to kind of hold onto the plate and feed themselves. And so I always support any parent's decision on whether they breastfeed, bottle feed, use purees, do baby-led weaning. Just the most important thing is that it's the safest way for that particular child.
Yeah. Yeah, I know for us, like when I was pregnant with Betty, that's kind of when I had heard more about baby-led weaning, and I was so excited about it. I was like, oh, I'm totally going to do that with this baby. And then, of course, she had all these challenges, and so it was not really an option. She was mostly fed with a bottle until she was almost 2. So that was kind of hard. But I think it's a great way to go, and hope to explore that if we have more kids.
And I think that's a really good topic to talk about is that, the number one thing is, we have all of these ideas in our heads when we're working with our kids and, that we're going to do this and then we're going to do that. And then kind of life throws a wrench. But that is the most important thing about any type of therapy and any type of parent decision is being able to make the right choice for your child. You didn't force it. You knew that, hey, we had to get good nutrition. We had to work on her suck. Bottle is the best alternative for that. And so being able to balance that and kind of let go of, our preconceived mindset of how we want to feed kids and being able to do what's right. So I applaud you for that.
Thanks.
You're welcome.
So what advice would you give to parents who are struggling with mealtime? I mean, we could do this all about my almost 5-year-old because Betty eats everything now, and my Clara she struggles. She's very picky. She doesn't want to sit down to eat. We've tried this is what's for dinner, eat it, or there's nothing else. And it's hard. So help.
So there's so many examples and tips and ideas. And I know that, this is just a shameless plug for Easy Peasy, but let me, before I answer that, let me explain why to the audience, why I'm going to talk about Easy Peasy products right now is I too came into Easy Peasy with the Kickstarter campaign and from a very different perspective. I, emailed Lindsay and I was like, this is literally the best product I've ever seen in the feeding world. And I was duct taping, plates and bowls and things, and to be able to have our kids with, motor challenges and any type of delay to be able to participate in mealtime. And when I saw their product, I was just absolutely blown away. And I was like, we have to collaborate. We have to do something together. We have to help kids. So just to throw that out there, I don't get paid to say anything about Easy Peasy. This was like a need that I had as a feeding therapist, struggling, working with kids on an hourly basis, feeding them and not really having the tools to be able to do that. So one of the best things about encouraging kids to eat and explore new foods is really using the Happy Mat. So this is a Happy Mat, and what it is this cute little face. And in January, our book comes out, and I think food art is so important to get kids to be able to want to participate in mealtime. And so being able to use a Happy Mat and make food fun and curious and interesting and engaging, you can't stop looking at it, right? It's so cute. And what that does is it just keeps kids engaged, so they don't need the TV, they don't need the iPad. Food art also really encourages them to try something new, because instead of you, mom, saying, eat your olives, we can say with this, hey, you want to try those eyeballs?
Right.
And it makes it, just that language use makes it fun. And so it really helps from the psychological standpoint of that. And then you're a cool mom because you're doing something fun, right? And so I love the language issues that surround mealtime. Instead of saying, Johnny, come to the table, dinner's ready. It's, Johnny, your happy mat's ready. Wait till you see what I did in the smiley face. It just changes all these words. And then with the happy mat too, it helps with kids to be able to, make the mess, feel free to explore, because a lot of parents don't like a lot of mess at mealtime. And so that the edge of the mat kind of holds all that mess for you, so those kids can really kind of explore that fun.
Yeah.
That's just one. But another way is just to be able to constantly think about textures, as well as ways to prepare them. So parents will say, oh, Johnny doesn't like carrots. And I'm like, oh, how have you given him carrots? Oh, well, raw. Well, did you try cooked? Did you try steamed? Did you microwave them? I mean, did you add butter? It's being able to have these multiple trials of trying it out and letting them know about that. So sometimes in a therapy session, when, they've offered raw carrots and it wasn't a hit, and then I'll say, oh, I steamed these carrots for you today. And they're like, what's steamed? And then, we're starting to use language and being able to kind of use that. But there's a few tips.
Do you have any thoughts on, like, I mean, I know for my daughter, if I say it's carrots, if that's the example, like, it doesn't matter if they're steamed or roasted, or she's just like thinks she does not like that food, and so she's not going to touch it.
So there's an introduction to foods and textures. And what we do is we find out what their favorite texture is. So let's say it's crunchy. So if a kid likes chips and crackers, and we try to, figure out what type of texture that is, let's say it's crunchy, then I will introduce the carrot as a crunchy food. I know that you like crunchy foods. Here is another crunchy food, or here's a whole array of crunchy foods, so that they can kind of understand what that texture is, because we all have texture issues and we all have temperature issues. And, I mean, that's the beauty of Starbucks, right? I can get it extra hot. I can, get it with 2 pumps of more vanilla. I mean, it's being able to really find out what you like. And so the introduction is, I made you a plate of crunchy foods. And no verbalization of what those crunchy foods are. Or I made you a plate of smooth foods, and no mention of what those smooth foods are. Because once we never say, as feeders, we never say, hey, make sure that you eat your carrot. I mean, make sure that you eat your cake or your cookie, or we never draw any attention to desserts. We always draw attention to vegetables. And so why do we do that? I mean, because, it's a psychological thing. Well, if mom's making a big deal about this carrot, let's say, then it must be, something that she wants me to have, not what I want to have. And so we, want the presentation of mealtime to be like we would present a birthday cake. Our language, I used to videotape that. Our language at birthday cakes is like, oh my gosh, look, I made this for you. And it's all this energy. And then when we bring out like kale salad, oh God, here's this kale salad. We're expecting, we're expecting that negativity. So being able to kind of try those different things. But I find that, explaining the texture and describing the texture, and then telling them that we actually, put some thought into that can really go a long way.
Okay. Well, along those lines, how much should we be catering to the pickiness of our picky kids? Like, do we need to make them a crunchy plate every time we sit down to eat? Or is it sometimes like, I made a roast and mashed potatoes, and so here you go.
There's no crunchy there.
Yeah.
Right. So it depends on what the goal is. So whenever you are getting ready to feed your kids, I always tell parents, what is the goal? Is the goal just they missed their lunch because they refused their lunch, and so the goal is they have to eat dinner? Then we need to cater to that. if the goal is I really want to introduce mashed potatoes, this, puree texture that they're not used to, then
Yeah.
we need to make that, mashed potatoes a little bit more fun. If the goal is that we're just going to sit down together for a meal and we're going to try to keep their attention the whole time for the meal, then that's another goal. We have to figure out what that goal is. And I tell families, make it a monthly routine, whatever that goal is. If the goal
Okay.
is to introduce textures, that's what you're doing for that month. If the goal is to, get 2 new vegetables in, whatever the goal is, we want to try to streamline that in our presentation. So with the
Okay.
roast beef, mashed potatoes thing, if it's puree she's not used to, then, can we, make that fun? Can we make a happy face? Can we give her, a squirt ketchup bottle and have her make a happy face on that and say, okay, I'm
Mm-hmm.
making this for a happy face. Here you go, Dad. Dad's making this for a happy face. Here you go. I mean, can
Right.
we try to encourage that? So it's just being
Yeah.
able to figure out what the goal is and then moving on from there.
Okay. So do you, with like older children, do you recommend presenting a plate or a tray that's full of food, or do you think they should be serving themselves from like whatever's on the table? Like, here it
So
is, you can take what you want.
I that's called a family mealtime, and I love that approach. Parents don't necessarily like it because then they put, 5 scoops of, macaroni and cheese and no salad.
Right.
But if you end up having a measurement system, whatever that system can be. So going back to the happy mat, we have the 2 eyes and the mouth. The mouth
Mm-hmm.
obviously has the biggest food, so the biggest size. So they can feel that happy mat filled with that macaroni and cheese, but one of those eyes has to have the salad. So it's being able to just kind of establish those rules and make that a routine.
Mm-hmm.
Whether or not they eat it is another thing. But being able to, there's so many studies that say if they're able to put that food onto their plate, they're getting used to that food more and more. They're smelling that food, even if they don't eat it, they're smelling it, they're engaging with it, they're, utilizing their senses. And from, again, this standpoint of socialness, by eating with a family mealtime really starts to portray the ability of them not saying, I don't like it, because
Right.
they've had it on their plate 20 times, whether or not they eat it. Is
Yeah.
that, but eventually studies show that they will try it. And again, we
Right.
don't make mention of it with my older kids. We don't
Yeah.
make mention of it.
Yeah. Isn't there something like you have to be exposed to new food X number of
Yes.
times before?
Yes. So there's different research, but I mean, then the number is usually 15, and that is 15 if there's no developmental delays. So
Right.
for kids with autism, it can take 100 plus times. So for one food, which is why, it takes a long time for those kids to, engage in new foods and be able to consistently eat them. And, we have to take into effect that, eating is just such a huge milestone to be able to have different textures. Just think about that. We're engaging in all the senses. We're engaging in all of our systems, digestion, etc., saliva production. There's so much to do from a child standpoint. And plus, we're dealing with a system with our kids that, these kids are constantly growing. So what they liked the day before may not be what they like today because their throat just changed or their tongue just got bigger or they just got 2 new teeth, or we're dealing with this system that is just constantly changing, and it makes it really difficult to be able to, interact with them. And that's why I think a lot of parents get so confused. Well, we tried this and now we're force feeding and then now we're bribing, and that, because the child is constantly changing because they're growing and developing, and we have to kind of catch up to
Right.
what they're doing.
Yeah. It's almost with any other routine. Like kids are always evolving,
Mm-hmm,
like
mm-hmm.
sleep and play and
Yes,
everything.
yes.
Um, Gosh, I had a really good question. The exposure to food, does that need to be on their plate right in front of them or in their
So
mat, or just on the table, or
yeah,
what counts as?
there are, different studies that show that just having you eat something in front of me exposes me to that food. Obviously, if I'm engaging with that food with a utensil, so if I'm serving and or putting it onto my plate, I'm engaging more about that. The more that we can get kids to engage in that food, the better it is. Because if I eat your mashed potatoes if I watch you eat the mashed potatoes, I'm seeing how hard you're biting, how much you're suckling, how many, how it's on your tongue, whether or not you can still talk to me and chew at the same time. I'm learning a lot about that. And then if I take that spoon and dip it into the mashed potatoes, I'm learning a lot about that sensory properties, how heavy the mashed potatoes is, how runny it is, how easy it was on the spoon, how that smells, what that sound is, being able to get that out. I'm getting a lot of information from that. And then if I'm able to put that on my plate, and then I can hear how heavy it is and then get the smell. I mean, even if they don't eat it, which is our goal as parents, right? We want to be able to get them to eat it. But even if we don't, they're that much farther along in the process of being willing to eat it. So it's, but watching you eat something, even if I'm not sure about it, I always take friends to sushi restaurants and I just, I'm eating the octopus and squid. I'm a huge adventurous eater. And they're like, I'm learning a lot about what you're eating, but I'm not going to try it. But they're still learning a lot about it, right?
Yeah. Say, come with me 15 more times, and then
you
will.
And you'll be eating it.
Okay, I got a question on my blog this morning and on the side about food strikes. The question on the blog was particularly about a child that had is refusing, like, even their favorite foods, just will not eat them. How do you manage that? What do you do?
So I think education is the number one thing. So let's look at the research on this. So there is a researcher by the name of Dr. Kay Toomey. She's a psychologist and she's done amazing work in our field of feeding disorders in order to be able to kind of give us the information to give to parents. So what she says is that there's picky eaters and then there's problem feeders. I don't really like either of those terms, but that's how she portrays it. So when a parent calls me and says, oh my gosh, I have a picky eater and they are refusing foods, they're going on food strikes, I have to start asking them questions. And so the differences between a picky eater and problem feeder is, number one, the range of foods. So if we start writing down all the foods that our kid eats, and for the parents out there, just start writing them down. And usually if a parent can like name them and they're counting their fingers, I mean, we know this is a problem. It's not picky. But typically a picky eater has a range of foods and a problem feeder has 20 foods or less. Okay. And so that's like a nice balance of foods. That we know, okay, this is really a problem and you should probably seek out a therapist. The second thing is food jags or food strikes. And what that is that if they eat, let's just say cheese pizza, and they're eating cheese pizza every single day, and then one day they wake up and they're like, I'm not eating cheese pizza. And then you offer it to them the next day and that was their favorite food and they're not eating it again. Mm-hmm. And then the next, if it's a picky eater, they'll usually regain that food in 2 weeks. Just like us. If we ate pizza every single day, right? And then we're out. But in 2 weeks, we'd be willing to try it again. But kids who are problem feeders, they don't regain that food. So that they will never eat cheese pizza again for the rest of their life, or they'll go 6 months to a year without eating cheese pizza. So that's a difference there. The third difference is the way that they're able to tolerate foods on their plate. So let's say we put the cheese pizza onto their plate, a picky eater will be like, Mom, I don't want that. Whereas a problem feeder has a huge behavior. There's a complete meltdown. We might not even get any food into that child during that mealtime because their system is so overloaded, and we all know what those look like. And then the fourth thing is picky eaters eat a wide range of textures and a wide range of different foods from different food groups. Whereas a problem feeder, let's say, only eats carbs and they don't eat anything in the protein category or anything in the fruit and vegetable category. So those are kind of the differences between that. Now, handling the food strike is different for each type of child. So if it's a picky eater, then we just want to keep trying to reintroduce that food in fun ways, but reintroducing it. It's a problem feeder. We are going to have to get really creative to be able to try to engage that food again. Because what happens is that if you have a kid that's eating the same food over and over again, you're going to have that burnout, because we all experience that as adults. You eat oatmeal every single day. You're going to wake up one day and go, you know what? I'm not eating oatmeal today. It's just the way that our bodies are. So I always tell parents, if you say, oh, this, graham crackers is his thing, he has to have graham crackers 3 meals a day. I'm like, graham crackers is the first thing we're going to lose. So we better start figuring out ways to mix that up because we're going to lose that food. And once you lose one food, then it's going to be another and another. It just ends up being this, because then you have only 10 foods to choose from, and then you only have 9. And then, so then you just start losing foods at a rapid rate. In fact, that's how a lot of my kids who are on tube feedings now started, is they started on a food jag and nobody took it seriously in the medical community. I mean, we are at a huge fault with that. We have pediatricians all the time that says, oh, it's okay, don't worry, they'll get that food back. Or it's okay, don't worry, all kids go through this. Or don't worry, it's a picky eating stage and they'll grow out of it. And they've been told that by so many different medical professionals. And then the kid has 5 foods and then refuses those 5 and has to be on a tube. And which is, happens to so many of my clients.
Yeah, that's a lot harder to deal with and recover from.
Absolutely. See, we're getting a lot of comments and questions. I can't read them at the same time.
Here's another one. Any experience with rumination and how to manage that behavior during mealtime?
Yes. Okay. So rumination is when we'll just say a child swallows something and then it comes back up into their mouth. And some kids want to spit it out. Some kids want to swallow again. Some parents are just completely grossed out by it. But it's a natural response. We all have some rumination. I mean, if you look at the end of your water bottle, you have a little bit of backwash in there somewhere. But when it becomes more and more of a problem, it can lead to what's called GERD, gastroesophageal reflux disease. And it can actually start to, have difficulties with the bacteria inside of the mouth. So there's different techniques for rumination, and even if they start spitting. So there are different techniques that will have a spit bucket so that they can actually spit that out, because sometimes there's so much acid in the food. So they swallow it and then, they may have some reflux, and now it's just a mouthful of maybe a little bit of leftover meat, but lots of acid. And, there's force feeding programs that says you have to swallow that again. Well, you know what? I'm not going to trust you as a feeder, and I'm not going to enjoy that food. And I'm probably going to lose that food because the last time I ate it, it tasted like acid. And I just feel like it's almost abusive to force a child to swallow their stomach acid,
Right.
Again, when they really want to spit it out. But we need to be able to add social skills in there as well. So if it's a child with special needs, a bucket is preferred over a napkin, just because sometimes they don't have the ability to wipe and be able to throw that away. Or a bib, like a lot of parents go to the bib and so that they can keep wiping. So it just depends. But if I see a child that has a rumination problem, that's one of the first things that I will contact is their GI specialist and see, are they on acid reflux meds? When was the last time that they were checked? The child's gained 20 pounds since then. Looks like we probably need to have a different prescription. Maybe we need to try a different medication. And so that's where, a team comes into play to be able to help a child with, severe feeding issues like that.
Okay. And what about like when a child refuses to swallow, like they just chew and chew and chew and chew and chew and chew?
Right. So chewing is a milestone and it's an art. And what happens is we need to be able to get kids to be able to chew for a munch chew like this and a rotary chew. So I always have props.
Oh, awesome.
So let's get it this way. So basically, when we have kids who have difficulties chewing, they usually can do a munch chew. But then when we put something here, and we usually want to put it on the back part of the teeth, kind of like what you're doing in therapy right now, and so that they can bite down, but they also have to be able to move their tongue. So if we work on chewing, exactly, lateralizing, we have to be able to work on the tongue, because the tongue has to be able to go over, grab that food and pull it, and then put it on the other side in order to chew again. So if we have kids that aren't able to lateralize their tongue, what else are they going to do? They're just going to keep doing this. And then eventually they just want to spit it out because they don't know what to do with it. Or they, just keep chewing for hours because they don't have the tongue ability to be able to move that. So we want to make sure that we have tongue lateralization in order to be able to chew. So that's one of the things that, speech pathologists assess is that, chewing might not even be a goal right now because we can't lateralize the tongue. And in fact, it might not even be a safe goal because they
Right.
can't lateralize the tongue. If you can't move your tongue to be able to protect your airway, you're going to choke. So, and then once a child chokes, there's research on this too, that once a child chokes, they can experience post-traumatic stress disorder and refuse to eat. And when they did brain studies of Vietnam vets and kids who have actually had a choking experience, it was equal.
Wow.
So, think about, wanting to try a new food, choking on that, and then who gave you that food? If it's mom,
Right.
that trust is starting to, break apart. If it's me, a feeding therapist, that trust is going to start breaking apart. So
Right.
chewing is really important, but we also need to be able to know what foods to try. So I liked more meltable foods like veggie sticks in order to be able to put that there instead of other harder foods. Or we try foods that are going to increase saliva. So have like salty foods, how you were talking about the pretzel, because sometimes the saliva production will help with tongue lateralization. It just depends. So it really is important to be able to pick the right food as well as pick the right technique to be able to help it chew.
Yeah. And if they're having a hard time with the lateral movement of their tongue, like this is something we're working on with Betty right now. And
Yeah.
I know you can't like be super specific, but like when we put things in, she'll move her tongue over, but then while we're eating food, she is just munching. She's not doing the rotary chewing.
Right.
So I have a hard time figuring out how to encourage the lateral tongue movement during meal time. Like we do the little exercises, but it's like, yeah, I'll do it now, but then when we eat, it's not going to happen as much.
So my recommendation for kids who have a hard time carrying over a therapeutic skill to food is the best way to practice is with food. So what I say is we do breakfast, lunch, and dinner, and then you have 2 therapeutic meal times. So that could be with a therapist, or that could be, away from the dinner table. So a therapeutic mealtime would consist of a snack. So let's just say these veggie sticks. And so we're working on those skills, and she sees on her plate, just veggie sticks, 5 veggie sticks. So it's a way for her to go, okay, I'm only eating those 5 veggie sticks. This is a technique I'm working on. I don't have to do a whole meal, and mom's expecting me to do a whole meal with a variety of different textures. Oh, we've got some, chicken nuggets, and then we have some watermelon, because those are all different, textures. And so we're just going to be focusing on one and just working on that one skill. And then, most importantly, you, mom, have to have a plate with 5 veggie sticks, giving that feedback too, right? And then also having a mirror there in front so that the child can be able to see what they're doing so that they can also get that feedback. Because what happens is that if we're not giving our kids the visual of us doing it or them seeing in the mirror, they're not being able to motor plan that effectively. Think of like, okay, we're all going to do a dance routine, but we're not going to have a mirror in front. We're going to do that dance routine really poorly because even if we practice it, because we're not getting that visual feedback.
Right.
So that's a general example of being able to transfer that. And then you start to transfer it. So if you're doing veggie sticks at snack, well, then we want to have veggie sticks at lunch because she's already been successful with veggie sticks. Right. And then, you might want to have a few veggie sticks at dinner because she's been successful. And not only her, everybody gets veggie sticks.
Right.
So she can see that feedback. And so instead of you saying, remember, you have to lateralize your tongue, you're eating that veggie stick and then dad's eating that veggie stick. And so she's seeing everyone doing that so that it encourages her to be able to keep practicing.
Okay. Yeah, that's good. Let's see. Did we have another question?
Yeah, I thought I saw something there too. Let's see. It's hard to. Thank you everyone for being here, by the way, and making comments.
Yeah, this is fun. And I did put a link in. I'll put another one in to Easy Peasy if you're not familiar with the
thank you.
trays because they're just so great.
Thank you.
What about playing with food? Do you encourage that?
Good question.
Did it happen during mealtime, or do we have special time set aside to play with food to explore those textures?
That's probably one of the questions I get asked most often by parents because they don't want to play with food. And here are some of the complaints. Usually parents are like, I don't want to make a mess. And so one of the ways that you can do it is on a happy mat, or do it outside, make it like some kind of a technique, or an outing. Maybe you do it at the park. You don't do it at home. Maybe you don't do it at the dining room table. Maybe you do it outside on the patio. Another is waste, food waste, that I get complaints about a lot. And again, when we're talking about food play, we're not talking about a whole roast beef. We're
Right.
talking about, a couple tablespoons of whatever it is that you want. So if it's, right now, with a lot of kids, we're working on foods for Thanksgiving. So if it's, corn or, green bean casserole, you don't have to make a whole entire casserole, but just get a little bit of green beans and be able to play with it and crunch it and move. If it's going to be turkey, let them, have a couple slices of turkey, be able to smell it, play with it, make, squishies with it, just be able to get the sensory aspects of that. It doesn't have to be a lot of food. And the time that it takes to be able to give them that food exploration and that sensory ability to be able to play with food, and just your one-on-one time will go so far into being able to try new foods in the future that might not actually require them to have the sensory aspects of having, food play. But being able to be allowed to play with their food is really important. And in most cultures, we're allowed to play with foods. I'm Hispanic. And so, you're playing with the food when you're trying to get that tortilla and get those, beans. In other cultures, they don't use utensils. And so they're being able to explore that. And they have the lowest picky eating rates. So we want to be able to encourage, kids to be able to explore their foods. And it's usually not years and years that we're doing this. It's usually a short period of time, especially when they're starting to be picky, or you see, that's probably a behavior that's starting to slowly but surely happen. So it's a short time frame. It's not something that, if you're with a therapist that's working on playing with their food for years, we need to move on from that.
Yeah. So sorry, you may have touched on this, but so the playtime should happen outside of mealtime?
Yes. And that's when we're trying these new foods. So let's say we're getting ready for, Christmas, and you want your kids to explore cranberry sauce. So the time to explore cranberry sauce is not when the in-laws and all extended family are there while you're putting cranberry sauce on your kid's plate. So we want to get a can of cranberry sauce and take it outside and just kind of play with it for a little bit and say, hey, we're going to have Christmas soon, and this is going to be there. And, and then take that cranberry sauce and put it on your own nose and, just kind of have some fun with it, so that when cranberry sauce is placed on their plate, they're not screaming and you're dealing with behaviors from the whole entire family that hasn't seen your kid in a year. So it's being able to prepare them for a sensory experience, and be able to have some fun with it. And I usually like to do it not at a mealtime, but, or if you're going to have cranberry sauce that day, do it earlier in the day and then have it at dinner time.
And then any tips for encouraging those boundaries? Like, we were in the backyard playing with this and I was painting my face with it, and now it's mealtime and that's not acceptable.
Oh, right.
Like, now the in-laws are here.
That's right.
So this is what we do with cranberry sauce.
Let's all be off here. Yeah. So what I use is language use, right? Just how we use our own language for, it's bath time. When we say it's bath time, it's bath time. That's what it is. Yeah. If it's, we're doing sensory time, we're playing with this new food, that's what it is. Then we have it's meal time, which is very different.
Yeah.
So it's being able to have time set up throughout the day in a child's routine, that we do every single day. It's time to read, it's time to take a nap, it's time to go to the bathroom. We have all these set times, and this just is another time set that's placed in there. Because I get that question too. I'm like, well, does your kid, play with bath toys, at home?
Right.
Yes. It's like, but those specific bath toys are not going to be at every bath time, right? So it's being able to, explore that language and being able to utilize that language in a routine.
Okay. Yeah, that makes sense for sure.
Thanks.
All right. We have another question. Okay. Any good cup recommendations for a toddler who has swallowing issues, not aspiration, just reluctance to take much liquid orally?
Yes. And I wish I had one with me. All my feeding tools are not with me at this moment. But if you go to talktools.com, talktools.com, they have a variety of different cups there. One of my favorite cups is called the nosy cup or the cutout cup. And what it is, it's a cup.
I have one. Do you want me to
Oh,
grab it?
sure.
Okay, I'll
Okay,
get it.
great. Hey, that's my
Just
favorite.
a second.
And basically what that is that it has this indention that's cut out so that when a child um, takes a drink, their nose can go into the cup and they can actually see the liquid. And what that does is that it keeps kids necks into the right position. So this position with drinking the chin down is a safer position because it basically our airway is protected. When we take a drink and we drink this way and we're tilting our head back, for those of you who are just listening to this on audio, and we tilt our head back, we are opening our airway. And so when we open our airway, the chances of that liquid going into the lungs is really high. So we want to be able to keep our kids' chins low. So think of Gatorade commercial, tilting the head back, bad. Drinking forward is better when we are talking about swallowing difficulties. You have the cup to be able to show? Oh,
Yes.
perfect. Okay, so this is Talk Tool's 1 ounce cup. And so you drink out of do you mind putting it to your lips? You drink out of that. Oh, yep, that side. So, yep. So that, see,
Like this was a while ago. We haven't used it in a while.
Exactly. So see how she can keep her head lower and be able to still get to the last drop of the cup. So there's different sizes. That's a 1 ounce. Good job demonstrating. And then there's a 2 ounce one, and then there's a 6 ounce one, I believe. And so we start with the 1 ounce to be able to get them to be able to what we call grade, and that's to grade the cup to get the right amount of the liquids to come out. And then we go to the 2 ounce. That's a little bit more, and we start to teach them how to grade that way. And I introduced that cup 6 months, at 6 months of age.
Okay.
And the negative of the cup is that it's plastic. And a lot of our kids who are really picky can taste that plastic. And so, you have to try it with your kid because it's hard to be able to get past that plastic taste.
Yeah. And I see that you are making a cup for Easy Peasy.
Yes, we are, which in the future you will see a wonderful cup. That's my favorite. But until then, that's my favorite.
Said that they used a medicine cup to begin with?
Yes. So, and that's really good too. So what a medicine cup is it's a smaller cup. The advantage of that is it's almost like a shot glass. You tilt it and you get a small amount, so it helps with drinking. But what happens is that even with the medicine cup, you have to kind of tilt your head back, right? Unless that medicine cup has a little cut out, but you're going to have to tilt your head back. And even though that's a great technique, and I've used it before to kind of do small amounts to be able to help the child with their swallow, we're still also teaching that motor response of them tilting their head back. So it's a great technique for short term. And go, mom, for doing that. But then you want to try to expand that to the nosy cup to be able to keep that safe swallow intact. Because once you start, getting to this habit, you start taking pills that way and drinking quickly, and it just really can put our kids at risk for choking.
Okay. The other thing we've used is like the honey bear. Do you recommend that?
Yeah, so the advantages of the honey bear, look at you have everything. It's great. The advantages of the honey bear is that you, the feeder, can squeeze and have that liquid come up the straw so that the child may only have to suck this much to be able to get it. I use a honey bear a lot with some of my kids with cerebral palsy, some of my kids with Down syndrome who have really low tone in their face, and so they're not able to have a good suck. And we want to teach the suck. But if the child has a difficulty swallowing, I will usually revert just to the nosy cup. But again, every kid's different. But I do use a honey bear, and I do like it. One of the
obviously a cup is ideal because that's what most people use. Like if you go to
And we want to, that's the goal, right? Is to have our kids be the most independent as possible in the least restrictive environment without our assistance. And so, if the honey bear does that, then it's making our goal. If it's a cup, and it's making our goal. If it's a medicine cup, we're making our goal. So it's being able, and to reassess though, always to say, oh, we've been using the medicine cup for 2 months, so maybe it's time to change. Or we've been using the honey bear for 6 months, maybe it's time to change, and constantly reassess and have someone to help you with that.
I did like it because it gives that feedback immediately. They get a little bit of liquid in their mouth, and then they suck, and I get more.
It's a great straw drinking technique.
to
And I love
start.
any of those
Um,
options over a sippy cup. So it's wonderful.
yeah.
Yes, drink from a straw or drink from a cup.
Do you want to talk about the downsides of sippy
Oh, sure.
cups?
Controversial. Here we go. So, advantages of the sippy cup is, it doesn't spill. Disadvantages of the sippy cup is that when our kids and just if you're using a sippy, there's no judgments, but look at the sippy cup so you can kind of see this. If they're using their teeth to bite the edge and it's tore up, those little bits of plastic are going into your child's gastrointestinal system. And so I'm not a fan of plastic cups. I'm drinking out of a glass, but with kids, it's hard with glass. So what happens with the sippy cup is that our tongues end up going forward. So we end up doing this with the drinking, and that's not how we drink liquids. So all those new water bottles that are coming out that have to do with the sippies at the end, even for adults, is that's basically pushing out our oral structures. It's pushing out our kids' teeth, so the chances of them having orthodontic issues are much higher. It contributes to speech impediments as well as lisping and other things. And there's no sound in the English language besides a th sound that has your tongue going out. That's the only one, that th, that. So all other sounds are inside the mouth. And so it also keeps our kids at a lower developmental age as far as their oral structures. And so they're not able to make all their other feeding milestones because the sippy cup is kind of holding them back a little bit. So I always say it's not a bad thing if it's used for short term, like if you're in the car, but then it's only in the car. Or we hydrate our kids before we go into the car, and we eliminate the sippy cups completely.
Okay. So straw is definitely
straws, and then drinking from an open cup. And when we're looking at developmental milestones, our kids are supposed to be able to start drinking from an open cup at 6 months of age. So when I see 4-year-olds on sippy cups, we're 3.5 years behind. And so then I'm always like, well, what's their speech patterns like? What's their feeding patterns like? We kind of get stuck in holding our kids back.
Okay. We have another question about constipation. Ideas for managing constipation naturally with diet, trying to wean off of Miralax. Yes. Also, alternatives for thickeners other than Thicket.
Oh, wow. Educated mom or therapist. Good for you guys. So let's talk about constipation. I never thought when I came into this field that I would talk so much about poop, but it really is a very good indicator, of our bodily functions, and especially for our kids. So what we want to do, and why physicians prescribe Miralax, is that we're trying to get the child's bodies back into normal function. And I always think we want to try to do that with food as much as possible. So to be able to help with a poop, we always do P foods with the letter P: pears, prunes, plums, papaya, pineapple, all P food, to be able to help with that process to decrease constipation. And we also want to be able to make sure that our kids are hydrated. And so the formula for that, and it changes a little bit with kids, but here's a great example, is you want to have your weight divided in half, and that's how many ounces that you're supposed to drink. So if you're 100 pounds, you divide that in half to make easy math, which is 50 pounds, right? And so that's 50 ounces that you're supposed to drink each day. And so another reason, again, don't work for Life Factory either, but Life Factory has ounces on the sides of their glasses. And so it's easy for adults to be able to measure that. And we need to do that with kids too. So they have smaller glasses for that. But we need to be able to measure ounces and how many ounces our kids are. We take them to the doctor, we get their weight. And so we have that accessible to us. And so, 50-pound child, divide that in half, 25 pounds, 25 ounces water a day. And that does not include teas, sodas, fruit juice. It's strictly 100% water. So if you want to stick some lemon in there or some to kind of have that kind of fruit infusion, it's fine if it's natural, but you want it to be water. And then depending upon where you live, you increase that by 10 ounces. So if you're in Arizona, you increase that by 10 more ounces. So if you're in a heater right now, it's just our first snow here in Colorado. So we have heaters
Here
going.
too.
You increase that by 10 ounces so that we make sure that it'll decrease the constipation.
Okay. Um, okay. So I think there was another question about, maybe no, there wasn't.
Yes,
Oh,
Jessica.
the
So much puke
thickening,
talk.
thickeners.
Sorry.
um, thickener.
Oh,
Did we already?
thickener. Oh, yes. So with thickeners, the pros of thickeners is that you can, buy a product that can thicken something very quickly. And why we use thickeners is because if I'm drinking this water is really thin and it's going to go down my throat really quickly. If I'm drinking, if I'm sucking pudding through a straw, that pudding is going to go down a little bit slower. If I'm sucking mashed potatoes, it's going to go down slower, or a milkshake, it's going to go down slower. So what happens is that my throat muscles, we can use this, my throat muscles move in this wave form to push down that water or push down that food. And so if you have a child with some low tone, that is not going to move as fast. So it's called peristalsis is the fancy term. And so that also can cause back end constipation because the peristalsis starts here at the throat and starts to move all the way down. It goes all the way down to our intestines and then out our anus. And that movement keeps moving that nutrition and then end up being that, bowel movement down. If you have problems here with your tongue and your throat muscles, and usually kids who can't lateralize their tongue, that's where the peristaltic movement starts. So we're starting here at the mouth and going all the way down to the digestive tract. So what thickener does is it makes that liquid go down a little bit slower so that our bodies have more time to be able to catch that and kind of move that down. The con of the thickener is that you have to get more nutrition in because it's thick. It's not hydrating the kid's cells. Thus, it causes constipation because you don't have a lot of hydration in there. So you want to, if the child has to be on thickened liquids because of their severe swallow, you want to have a lot of foods, specifically fruits and vegetables, in their diet to be able to help add that extra hydration into their body.
Okay. Did you have any ideas about natural
Oh yes, sorry.
thickeners?
So
That's okay.
so there's a variety of different things out there, and if you want to go more natural, there's the different corn starches or different oatmeals, and but again, anytime that we thicken something, it's decreasing that liquid. So what I try to do is as a feeding therapist, I try to make those goals with the parents that we work with and say, okay, mom, we're on thickened liquids. Let's say it's pudding thick, or there's different types of ranges of it. So it's nectar thick, pudding thick. If it's nectar thick, I try to use natural fruits and vegetables to be able to thicken it. So, and you can make your own juices and, Vitamix blender or a regular blender to make things thicker and just add in a little bit of water. If it's a pudding thick, that's when, you pretty much have to use the traditional thickening agents to be able to help with that. But if a child is just on a nectar thick liquid, I usually try to do it naturally. Now, with that said, for the therapists out there, as well as parents, this is another thing that you have to reassess constantly, because even thickening a child's liquid is changing the anatomical response to food. And so if it sounds so passive, being able to just put a child on a thickened liquid, but it really, for those of you that are out there with the kids with constipation, we are changing a whole dynamic of someone's lifestyle by thickening a liquid. And so I always reassess. I always try thin liquids when the kid is at their best. So if your kid is, really strong and motivated in the morning, try thin liquids in the morning. If they fatigue over the day, then start to thicken their liquids throughout the day. If they're rock stars at night or right before they're about to go to bed and they have all this great energy, we want to try some thin liquids there. So we want to reassess the situation consistently and make that be a question that you're asking your feeding therapist over and over. Let's reassess, let's reassess, let's reassess. Because there's plenty of times that I get kids that have been on a thickened liquid for a year and, we reassess and they're totally fine. But,
Right.
but it's like a medication, you're fearful because
Yeah.
you don't want it to go down into,
Yeah.
our kids' lungs. We want to protect that airway.
Right. So I know we have a few parents that watching that have not yet started feeding therapy, but they know that that's coming up.
Yeah.
So, what should parents ask their therapists, like as they're getting started, and what can they expect during a feeding therapy
Oh,
session?
wonderful. Great question. So I think the first one is to ask the therapist before you go there if they're comfortable having you in the therapy session. Now, there are those kids that I've seen that, I'd love to have mom involved, but when mom's there, the kid just won't pay attention. They want to be in her lap, or they want to breastfeed, or they want, they're not paying attention
Mm-hmm.
in the therapy session for whatever reason. And and I completely understand that. But for the parents to be able to have the best outcome in feeding therapy is if they're in there, because they're a primary feeder. So we don't make any gains if the child only eats with me and doesn't eat with mom or dad or grandma.
Mm-hmm.
So, but there's a lot of
Right.
therapists out there, and it is not saying anything bad about them, is that there's just a lot of therapists out there that just aren't comfortable having parents in the therapy session. And so they just don't
Mm-hmm.
want to have them. Or there's clinics out there for a liability standpoint, they don't have the therapists have the parents come in. But again, I think we lose the most important feeder in this whole session is
Yeah.
and then we're trying to gain that trust. So if I'm able to feed a child with a spoon and then I give that spoon to mom and the child doesn't eat, how I mean, what's 1 hour of therapy a week going to do? It's not going to change anything.
Right.
So we have to have the parents' involvement, and plus, and it's really important to have that involvement, because if I'm about ready to try a new food and the parent is like, oh, they're allergic to that food, or we haven't tried a prune
Right.
before, or I mean, there's a lot of
Mm-hmm.
feedback that goes in. And part of the therapeutic process is for me to be able to pass baton to mom or to dad or to grandma or nanny, whoever it is that's going to be that primary feeder, and be able in the feeding therapy session to reassess that as well and be able to give tips and tricks. So the first thing I would say is to see if you're allowed in the therapy session. And then the second thing I would say is that bring the plates, the spoons, the cups, the bottles, the sippy cups, um, into the therapy session so that the therapist can evaluate all of your products. And that gives me a lot of great indicators. So a parent will bring a sippy cup and they're like, "Oh no, it's okay because I took this out and I've adapted this," and or we used duct
Mm-hmm.
tape on the edge of this spoon so he can hold it better. It gives me more information about what I'm working with. And
Right.
then the third thing I would say is to ask them specifically what their continuing education is and what techniques they're certified in. There's a lot of therapists out there that have only been certified in one approach, and our kids are not cookie cutters. It's not one size fits all. You have to have a wide range of different techniques and continuing education underneath your belt to be able to service a vast population. So I love it when parents interview me on the phone before I ever see their kid. They're just like, "Where'd you go to school?" And I'm like, "Oh, let me tell you all about myself." Like and I really respect that, because I'm going to be in your kid's mouth. I'm going to be feeding them, or I'm coming into your home. Guess what? I'm going to be at your dinner table. So I think it's really important for parents to interview their therapists and make sure that they're a right fit. And then lastly, I would say make sure that if there's no love connection between the therapist and the child, move on. And there's been
Right.
several times in my career that I'm Latina, I'm loud, I'm touchy, I move a lot, and for some kids, that's not the right fit. And as much as I try to keep my hands together and keep my voice down, it's just that's not a natural thing for me to do. And so then that love connection is not going to be there. And we want them to trust me, and I want to be able to get into their mouth, and so that's going to be really difficult. So I have a
Yeah.
lot of parents who say, "Oh, I just don't think that the therapist loves my kid," and as ridiculous as that does sound, you know, because you may not be there to for your kid to be loved or there to be taught. I mean, I work with like I just I could easily adopt most of my caseload because it's you love them, you feed. And that's one of the beautiful things about feeding, is that you're that's one of the ways to show love, is to explore foods and to feed. And if you don't see that compassion in the therapist, it's just we have to move on and try to find another therapist that'll work with you.
Great. And then any tips about what a parent should expect during a feeding therapy session?
Yes. Oh, good one. So this is my biggest tip. If your parent, if your therapist gives you homework. So, and that being said, is I don't have, here's 5 handouts and I expect these filled out, but the next time you come, it'll
Right.
be like, okay, hey, we're trying the nosy cup in the therapy session. It's like, hey, mom, I'd like you to go onto TalkTool's website. I'd like you to buy a nosy cup and then bring that to the next therapy session. That's your homework. So
Mm-hmm.
you're leaving the therapy session going, okay, I have a plan. I'm glad to buy this. And then the next therapy session, like, oh, she's drinking really well with it. Okay, make sure that she has her lips onto the cup. And so your homework is, mom, is, do this during snack time and make sure her lips are on the cup. I don't care how much she drinks, make sure her lip is on the cup. That's a homework assignment.
Mm-hmm.
Or it would be, okay, I want you to monitor how much she's drinking because we're trying to tackle this constipation. That's a homework assignment. I want to be able to make my goals that I have written down on paper saying that I expect the child to reach XYZ. And the only way that I can make that happen is if there's carryover. Mm-hmm. So we want to make sure that they have homework. And then you want to be able to feel like your voice is being heard. Yeah. And I think making sure that that time is scheduled into the therapeutic session is really important. So I usually will say I have a 50-minute therapy session and the last 10 minutes is parent, discussion so that we can answer any questions. And then what happens is that you as a mom don't have to feel like you have to send an email after the therapy session. I don't have to feel like I have to, respond to it. We have that scheduled time to be able to discuss it. And I think that's really important.
Great. All right. Well, did you have any other things that you were hoping to talk about or discuss with us?
Yes, actually, yes. I do.
Great.
I wanted to, because I know through Twitter, a couple of my feeding therapist friends were coming on, and I wanted to show our product that's going to be coming out soon. And this is called the Mini Mat. And this is going to be able to be transferable. So it's going to be in a clear pouch so that parents can put this into their purse. And so it's going to be more of a travel mat. Which still has a suction function and everything in it, and as well as being able to fit onto most high chairs. And I also wanted to talk about the differences between a feeding disorder and a swallowing disorder, because I kind of got that asked on Twitter to make sure that we discussed that too, because parents are saying that their child has been diagnosed with a swallowing disorder, but they don't feed. And so I just wanted to clarify that. Okay. So basically a feeding disorder from ASHIS says is that a child has problems gathering food, sucking it, chewing it, or swallowing it. And that's a feeding disorder. And so it sounds very similar to a swallowing disorder, but it also gives us more information about which therapy that we're supposed to go to. So if you have a child that's not able to get the food from a fine motor standpoint and put it into their mouth, that's not speech, that's OT. Right. If once they get into the mouth and they have difficulties sucking or chewing or swallowing, that's traditionally a speech language pathologist. So sometimes you have a whole team that's in there, which would be, a GI doctor, a primary care physician, or a pediatrician, and a speech pathologist, an occupational therapist, and a dietitian, to be able to all work as this collaborative team to be able to work on that. And then a swallowing disorder is any problem in that step. So we break it down as an oral phase, which is basically in the mouth. So if, rumination is an issue, chewing is an issue, keeping food in the mouth, drooling, being able to not lateralize their tongue or their tongue sticking out all the time. That's all the oral phase. Then we have pharyngeal phase, and the pharyngeal phase is that the throat muscles are not able to kind of have that peristalsis, or there's coughing or choking or gagging. That is the pharyngeal phase. And then there's the esophageal phase, the esophagus going down. And that is the phase that a speech pathologist can't assess. It has to be through x-ray, through what's called the modified barium swallow study. But if your child has issues with the oral phase or the pharyngeal phase, that's our area of expertise, and we're able to kind of get in there and assist. We have a lot of kids who have feeding disorders and swallowing disorders, and some kids who just have swallowing problems. They'll eat anything, they eat a wide range of foods, but they choke every single time. So, and that's just a swallowing disorder. So hopefully that kind of separates the two.
Yeah. Any tips on gosh, as parents, it's like we're encouraged, like you have to be your kid's advocate. And when there's so
Yes.
many different people involved, and ideally it's like you have this team that like would meet together and have the same purpose and
Yes.
mission, but in reality that very seldom occurs.
Yes.
Any tips on getting like all of your people on board with like the same treatment plan, or communicating different information, different recommendations between doctors and
Yes.
therapists?
Oh, that's a good one. Um, I love the moms that come into the office that have a binder this thick that are just like, here is my daughter's history, because I know I'm going to get all the accurate information. I know that I can say, hey, can I have copies of these 4 reports, and then put them into the file, so then I can be able to communicate effectively with, the appropriate medical team. It's really hard for therapists to be able to attend, the IEP meetings, unless you're just getting that from the school. And 9 times out of 10, you're not getting feeding therapy in the school system.
Right.
To be able to have outside therapists come into an IEP is, pulling teeth. So it's usually over email. I prefer to be able to do Skype meetings, or be able to talk to them on the phone, or we can do a conference call to be able to get the whole team involved. And it usually has to be the one person that is kind of taking the lead. 9 times out of 10, it's a speech pathologist, but asking them to be able to take on that role is a huge responsibility because of time management issues, depending upon your insurance and et cetera. So then it usually ends up being the parent that ends up having to do that. But I think it's really important for us as therapists to be able to advocate for them, because most of the pediatricians don't understand how serious it is. And so when I'm in a conference call with a pediatrician, they're just like, really, come on, all kids are picky. And I have to throw out statistics. Like, actually, 5% of the children I work with will starve themselves. And I've gone through more, children funerals than I care to, tell anyone here on this show, because people don't take it seriously and kids won't eat. And it's a disorder, and that's why we're here. And I have to really explain to them that 8% of the pediatric population in the United States have a feeding issue per ASHA, and or a communication disorder and a feeding issue at the same time, which makes it even more difficult because we don't know
Mm-hmm.
why the child's choking or swallowing. So I have to kind of like rattle off all these stuff, that 1.3 billion people in the world have disabilities that include swallowing disorders. And
Mm-hmm.
so, this is a huge population, but we still have a medical community that don't take picky eating seriously. So it's being able to advocate for them, being able to all be in on the same team, and also to have everyone feel like their voice is heard, but most importantly, that the parent really collaborates with what the diagnosis is. And so that may be, for example, your daughter, it may just be the spoon. It may not be a true swallowing issue. It may be the spoon, right? But if
Mm-hmm.
you're thinking it's a spoon and I'm thinking she has a severe swallowing problem, we're stuck.
Yeah.
We're not a collaborative team.
Yeah.
And so we all have to really agree on that diagnosis and agree on that treatment plan, which is, a big part of advocating.
Yes. Great. Did you have any other topics you wanted to touch on?
Oh, I could talk all day. I'm a
Yeah,
speech
this is fun.
let me just advocate a little bit for my profession. There's a lot of people, especially parents, who say, oh, you know what, I've been seeing a psychologist for, my child's feeding disorder, or I've been seeing a social worker for my child's feeding disorder. And just kind of separating the differences between, an eating disorder and a feeding disorder,
Okay.
bulimia, anorexia. Maybe our kids are having some rumination, or maybe they're spitting up some, but it's not a true eating disorder. These kids, have some medical complications that causes, feeding to be very challenging. And I think it's really important to be able to have a group of people that you can go to. And one of my favorite places to send parents is a place called Feeding Matters. And so it's feedingmatters.org. And that's a group of parents who have kids that are on, G tubes or severe feeding challenges, or, have been force fed. And anyways, it's a group of parents who started it. It was called Popsicle before, and it's now called Feeding Matters. And they have national conferences, and they get the best of the best in speech pathology and occupational therapy to be there to give conferences to educate parents. And so I think it's really important to be able to have a group that is able to kind of give support. And then you're part of a whole bunch of face groups, right? That kind of talk about that, because I think it's important for parents to say, oh, I found this great therapist, or I found this great pediatrician. And really it's like, that's the best marketing that you can ever get, is being able to, hear it from another mom. Right.
Yeah, for sure.
So I can literally talk your all's ear off forever. So we can stop at any time.
Did anyone else who's here have any questions? If so, you can just type them in the little chat bar.
Lots of comments. Thanks, guys. And thanks for all the love in the corner.
Yeah.
Yay. Thank you. Thank you so much. I really appreciate that. And thank you. This is really a passion of mine, is being able to educate parents and therapists. And I think it's going to make such a huge effect in our kids and for the kids that follow behind us. In therapy, is being able to really get it out there and let people know that, feeding struggles exist, and that it does take a team, and it takes a lot of time and energy on the parents' part to be able to drive to the appointments and get the right tools and do the education and, take the time to be on, social media like this to learn that. And, I'm so grateful for you guys being here and being advocates for your kids.
Yeah, well, thank you for all that you do and for being here with us. It looks like we got a couple more people that just hopped in. We're about to finish up, but we will post the replay on both of our websites. And just to reiterate, I'm Sarah Evans. I host the podcast Bringing Up Betty, and
I'm Dawn Winkleman, and I'm a speech language pathologist and feeding specialist for Easy Peasy. And I just see that Feeding Matters just joined. I just did a plug-in for you guys a few minutes ago, so listen to it.
Yeah, and here's the link to easypeasyfun.com, and then I'll post a link to Bringing Up Betty.
Thank you.
And let's see if this is going to work.
And we'll put it on our social media. And for parents who still want more information, you can go onto our blog on easypeasyfun.com. And I have wrote a lot of blogs that have to do with feeding. You can also go to our Pinterest page. We have a Pinterest that separates things for snacks, breakfast, lunch, dinner, in order to be able to make things easy for you, as well as a feeding and swallowing board and feeding therapy board. And we post a whole bunch of stuff on there too. So feel free to utilize us as a resource, and Bringing Up Betty as a resource. I've been listening to her podcast. Amazing. Feeding Matters, Talk Tools. There's a lot of us out there that specialize in this. Another plugin is a friend of mine who actually does in-home therapy too, if you're in the state of Colorado. And her website is mymunchbug.com. And she has a #1 feeding book right now on Amazon, which is called Raising a Healthy, Happy Eater. And her book is phenomenal if you're a parent that's wanting to kind of get some more resources out there for you. So
great. Thank you. That's awesome. And I will post all the links to all the things we've talked about today on my website. And yeah, I think that's it. So thank you so much for all of your great tips and advice. And thank you for everyone that joined us. This has been really fun.
Thank you so much, you guys. Bye-bye.